All right. So I had a request from a few students to go over pediatric medical emergencies, and I was thinking it would be way longer than I care to do a single video on. I'm pretty disciplined about trying to keep it to 15 to 20 minutes, not just for attention span, mostly because my upload speeds for my internet suck. And so every time I do like a 20-minute video and try to upload it takes forever to do. So this will probably be a multi-part thing. So um, I just realized how much of a hipster I look like. That's cool. I like my hat. So, anyways, without further ado, I'm going to go into some pediatric stuff. I like going over pediatrics now. I used to hate it. I used to not like pediatrics at all because it's one of those calls when EMS you get real nervous, especially if you've not been around pediatrics a whole lot. Personally, I had to go work at a pediatric urgent care for a few years, and just getting exposed to the kind of illnesses and the traumatic injuries and stuff that kids of all ages would come into our urgent care with was really eye opening. And it was the best education I received. Like, you can read stuff in the textbook all you want. You can get trained to answer the questions appropriately, to use the resources and stuff, but it's quite something else to deal with pediatric patients one on one when you're with them in the back of an ambulance. You're trying to console the parents and you're trying to understand what's going on with kids. Now, don't get me wrong. I still get nervous with them, but not as nervous as I used to. I feel like I have a little bit of resiliency. So, if you want to get that, try to get some pediatric experience in an ER clinic wherever you legally can. When you get your EMT, advanced EMT, or paramedic license, it'll be a game changer. So, when it comes to pediatric um, emergencies, there's a few things we need to consider. One of the things is you get dispatched out to, like, let's say, choking, seizures, unresponsiveness, diabetic emergency, and then you go to your CAD or you go to your computer system and you see, oh, it's a 2 year old, it's a 3 year old, it's a 4 year old. And you were probably expecting a 20 year old, a 30 year old, or a 40 year old. And all of a sudden you're like, oh, crap. And I think the hesitancy we have for dealing with them and the anxiety that comes with kids is we just don't get exposed to them a whole lot. We don't get to see them a whole lot in the field. I see on average maybe one or two a shift, or one or two a week. Just depends on how my shifts are going. So we don't really get around them a whole lot. The other thing too is things kind of change. They're not just like tiny adults. They're tiny adults with big heads. Now there's a lot of different anatomical things that are different with them, obviously, but our resources are different. The way that we're going to secure them is different. The tools that we have in the back of our ambulances, everything's different because kids come in different shapes and sizes and varieties. And if you're using any of those length-based tools like the Broslo tape, there are different colors on them, like red, purple, gray, orange, blue, and all of them have different size OPAs, NPAs, different doses for everything. So pretty much we can get overwhelmed very quickly. So one of the big things that I've taken away from pediatric emergencies is stick to the basics. Whenever I'm going on a call to a pediatric patient, I'm always thinking in the back of my head, or even verbalizing it out loud with my partner. Hey, we're going to make sure that we have the patient's airway. So as soon as we get there, as long as their airway is open and patent, as long as the patient's ventilating, hey, we're doing good. If you can get those two things um, well on the patient, then you're in a good place, because the number one cause of cardiac collapse in the pediatric population usually has something to do with respiratory effort. So when it comes to pediatric patients, I have this little EMT overview, and I have a mind map. I like using this tool. It's a Google LM notebook, which, by the way, I'll link all this stuff in the video. I have some videos that I want to show and a cool little PDF. So the first thing is general principles. When it comes to kids, rapid assessment is essential. It's really essential for even adults and everything too, but even more so for kids, because man, we get on scene, like, if parents are usually calling us care providers and stuff, they may be panicking, kind of freaking out a little bit about what's going on with their kids. So we have to do a pretty rapid assessment. Um, I also talk about early recognition of decompensation. Children are master vasoconstrictors. They will constrict like crazy, and they will compensate, and then they will go into decompensation and failure so quick. So we have to be really careful because children do crash fast. They compensate really, really well until they don't. And the big key areas that we want to be concerned with is just airway, oxygenation, ventilation, and then definitely our circulation. So, how do we recognize when a kid really needs help? Well, there is a specific tool for that. We always have tools for that. It's called the Pediatric Assessment Triangle, and it's a little different than your typical A, B, C, D, E that we use for the adult population. You still use your primary assessment, but the Pediatric Assessment Triangle lets you look at a kid. So within 30 to 90 seconds, you kind of have an idea of like what's going on with this kid, how sick are they. And the pediatric assessment triangle deals with the appearance. How does the kid look? Their work of breathing, and see their circulation. So their skin color, condition, temperature. Their appearance is basically, are they interacting with the environment, or are they listless? Are they limp? Their work of breathing is, are they working really hard, or are they not working at all? Or is it just like normal, adequate effort? And then C, circulation is, do they look shocky? Do they look pale, cool, diaphoretic? Is their skin flushed? Those three elements should let you know if you're dealing with a kid that's really sick or not sick. And you can determine their stability or their instability pretty immediately. And like I said, the three components that we deal with is air appearance, work of breathing, and circulation to the skin. When it comes to appearance, there's another acronym. We love our mnemonics. We love our acronyms. This one is TICKLES, and it stands for tone, interactivity, consolability, look or gaze, and then S is speech or cry. Now, I didn't make any of this stuff up. In fact, here's this really cool website that, again, I'll link it down in the, I'll link it into my video. But when it comes to kids, um, you can use this pediatric assessment triangle. T is for tone. Basically, how is the kid? Are they moving their arms and legs around? Are they moving around like they're supposed to, or do they appear listless? Are they interacting with their care providers, with their parents, with the responders on scene, or are they not interacting at all? Are they gazing off into like? Are they just kind of laying there? C is consolability. Is, can they be consoled by their care provider, by their parent, or whoever's over them? Or are they inconsolable because they're in a lot of pain, they're really sick, whatever? L is for look or gaze. Are they tracking you? Are they looking at the parents? Are they looking at their dog that's walking around? Are they looking at you or your responder? Um, I've noticed too that until I had kids of my own and until I was around children at the urgent care and stuff, I really wasn't that great with kids. And now I don't think I'm the best with kids, but I do think I'm a lot better with them when it comes to just interacting with them, trying to play with them. Which, by the way, the smaller they are, the less you should be adapt to give them like small toys. So if you have like fluffy toys or their favorite blanket or their toy that they like to play with, use that to your advantage to see if you can interact with them, see what they're looking at. And then S is speech, or if they're too young or they just don't have the development, their cry. Do they have a strong cry or not? One of the best sounds you can hear when you get on scene, and I know there might be some people who are listening to this going, is that cry. And that's absolutely true. If you hear a good strong cry, you know their airway is good, you know they're breathing. We don't know about their circulation just yet, but we know at least their airway and their breathing is good. So yeah, T is for tone. So they have good muscle tone, or they limp like a rag doll. They kind of flop around. That can happen sometimes, especially with seizures. The younger they are, the more apt they may be, or more prone they may be to even febrile seizures. And a febrile seizure may be something that they had before, or this might be the first time they've ever had it. That's when we start getting a good history from the parents. So a good strategy may be to have one EMT, one AMT or paramedic, whatever, start doing hands-on assessment with the patient while your partner starts asking questions to the care provider or family that's on scene. It's like, hey, have they been sick lately? Any fevers? Anything you noticed? How long have they been out? Have they had seizure activity? How long was that seizure activity? There's a lot of questions. And speaking of questions, whenever you're taking notes and you're like, wait, what questions do I ask? Sample, OP, QRST are always really good questions. Those are baseline, foundational, fundamental questions. However, when it comes to specific populations and specific problems like medical emergencies and stuff, you may have to refine your questions and ask better ones. Like, how many diapers have they been going through? Is that normal for them? If they had seizure activity, how long did it last? Have they ever had this happen before? If it was febrile in nature, like if you're the one that's evaluating the patient and you overhear them say, "Yeah, he's had a fever and he feels hot to the touch," you may be like, "Okay, well, how when did the fever start and what was the T max? T max is just temperature max. How high has the temperature gone with them?" I always tell parents too is like, if they feel hot, they are hot, regardless of what that thermometer says. Sometimes these thermometers are off and they're just not that accurate. The best temp we're going to get on any patient is really going to be a rectal temp, especially your young pediatric patients. There's no reason why we shouldn't be getting those if we have the time and effort and resources to do that. Yeah, are they lethargic? Are they active? Do they hold on to their caregiver? Is that even appropriate for them? Um, so yeah, you can see the little babies here. Like, eh, the first one on the left, that look, she looks like she's just passed out. The other one does too. Look like they're just really tired. Eyes for interactivity. So, are they playing around, smiling? Are they following you with their eyes? Are they hiding, fearful? Are they turning their head to the stimulus? And really, this video isn't about going into the tickles mnemonic. It's just giving you another opportunity for you to see that there's a little bit more to the evaluation process when it comes to the appearance. And you may think, wow, this is a lot, but it's really not. Like, once you like identify the different variables of tone, interaction, consolability, look, gaze, speech, and cry, you're going to get it kind of automatically. Your spidey sense is going to tingle. You're going to be like, oh, this kid doesn't look like he's interacting appropriately. Like, if a baby or if a child allows you to pick them up and they don't really fight you or anything, that could be a bad sign for them perfusion wise. They may be altered, they may be lethargic. So if there's any part of you that thinks that the kid is sick, then they probably are. The other thing we talk about is work of breathing. Notice it's not just breathing, it's work of breathing. Like, how hard are they breathing? And sometimes you can get that right off the bat. As soon as you walk in, you can be like, oh, that kid's having a hard time breathing. I can tell they're having a hard time breathing. However, sometimes you can't. Sometimes you won't really see their work of breathing until you get shirts or onesies off of them so that you can actually look at their chest and their abdomen, because sometimes they may have these things called retractions, subcostal, intercostal retractions, and you will not see that, especially in these cold environments when patients could have like bronchiolitis, croup, all these asthma, all these other little issues, and they may be bundled up. They may have a lot of clothes on, so you may not be able to see them. You won't see them until you actually start looking at their chest and abdomen and then cover them back up, because we want to prevent them from getting hypothermic. The younger they are, like we're talking about babies and infants at this point, where they may have what's called nasal flaring, where their nares try to open up and get as much air as possible flowing into them. And because think about babies, they just don't have the same musculature and resources to recruit the same muscles to pull their chest wall up. So they have different ways of trying to get air in. One of them is going to be nasal flaring. Another one's going to be head bobbing. They're going to try to go up for some air, and then their head comes back down. And they'll go up for some air, and then their head comes right back down. We can also may even hear any abnormal breath sounds. Inspiratory stridor is a big one. Inspiratory stridor is that every time they breathe in, you hear some sort of like high pitched noise. That's usually an indication of either a foreign body airway obstruction. It could be swelling from a viral infection or swelling from a bacterial infection. It could be from croup, and that's a viral infection that would cause some swelling. Inspiratory stridor at rest should be also considered to be a danger sign, because anytime you hear inspiratory stridor, there's something in the airway, and that could be an impending airway collapse. What we don't want to do is make the mom or the kid panic anymore. Best thing we can do for them is try to calm the situation as much as possible and get them rapidly transported to the nearest appropriate facility. Wheezing, you're probably not going to hear it until you put a stethoscope on them. Like, especially the smaller they are, man, you just don't hear them. Like, you might hear an adult wheeze because they have the tidal volume that you can hear that from. It's different when you get to kids. You may not even hear them wheezing. Sometimes they're wheezing and you just can't hear it because you're just your stethoscope just can't pick it up. But they may have that shortened inspiratory and prolonged expiratory phase, and to me that would be, hey, that's might be some air trapping that's associated with some wheezing. So as an EMT, may be able to give albuterol to help open up those bronchioles and see if we can move past it. And what's interesting is if you give someone albuterol, they may start coughing more. So especially with children, if they have like a non-productive cough that's been going on for a little bit, and when I say a little bit, I'm talking anywhere from hours to days. You might want to listen to their chest, and if your protocol allows, administer an albuterol treatment. They may start coughing more, and then you may start hearing the wheeze because now it's opening up, and you can actually hear that that tubular flow go through those mucus or inflammation, whatever it is. And then, of course, the typical tripod position. If they're old enough, they may try to tripod, and that's just so that they can increase that surface area. The last part of it is going to be the circulation to the skin. So kids are really good at. They're kind of like mood rings. I don't know. I grew up in the '90s, so mood rings were this like little ring that would change colors depending on your mood. I don't know if that thing actually worked or not. It's a sales gimmick, but kids are skins are like mood rings. They'll have rashes on them, and most parents know if a rash appears on your kids skin somewhere, you're in for a long day or two or night or two because they're going to be up coughing and sneezing and all that fun stuff. Because kids' skin shows the signs of their disease process or their illness process, especially if they're getting shocky. If Because the first thing kids love to do, again, I told you they're master vasoconstrictors because they have not had as much pizza and McDonald's and spicy Cheetos and Coca Cola and all the stuff that we love to eat. They haven't had a lot of that stuff just yet. Chicken nuggies and all that fun stuff. They haven't had all that. So their vessels are extreme. They have great A1, A2 receptors. They have great beta 1, beta 2 receptors. Those vessels will constrict like crazy to the point they don't even want to walk. Why don't they want to walk? Because it feels like pins and needles. Why does it feel like pins and needles? Because they're constricting. In fact, if you do their cap refill, you may want to compare a distal cap refill to a central cap refill. What I mean by that is, you can just pick up their hand and press down on their thumb on their nail bed and see how long it takes to go back to its baseline color. And then you can do that to their earlobe or on their forehead or somewhere it's kind of centrally located, like on their chest, and see what the difference is. And that kind of tells you where they're progressing in terms of shock phase if they are starting to have any sort of circulatory issues. The other thing too is they like to have reflex tachycardia really well. So they're not only master vasoconstrictors, their heart rates will go high. It's always good to know the normal parameters for infant, for newborn, toddler, preschool, school age children to kind of get an idea of where the heart rate ought to be. But if it sounds fast, it is fast. And getting a pulse on babies and small children is almost impossible. Like, I'm not saying you can't, but try to palpate a radial pulse. You can't do that on a 2 year old. Um, you can barely get a carotid pulse, and I wouldn't even try to get a carotid pulse because, especially with babies, their rolls have rolls. They're just really big, like chunky things. Like you're not going to get your fingers up to feel that carotid pulse. You might be able to feel that radial pulse. The best thing you can do, put your stethoscope on their chest and listen to heart tones. Now, you're not listening for S1 or S2 or S3 gallops or anything like that. You're literally just listening to heart tones and actually hearing their lub dub, the S1 and the S2, lub dub, lub dub, lub dub. And if it sounds fast, it is fast. You're like, wow, this is going really fast. I wonder how fast it is. Like, yeah, you could do your best to try to count it. Put them on a pulse oximetry, see if it can kind of like match up to what you're getting with your stethoscope. Because if they're going really fast, we're talking they can go in 160, 180, and 200. Just because they're compensating for something. And that ought to be a good red flag for you to be like, hey, they're compensating. It means they probably ought to be doing something to get their fever down or get them the antibiotics or get them to a hospital where need to get rehydrated, whatever it is. So there's a variety of reasons why they may have a decrease in perfusion and cool extremities. We can also look at their skin, see if it's pale, mottled, or cyanotic. Sometimes parents will even say, "Hey, they went blue for a little bit, and then they're pinking back up for whatever reason." Those are usually called bruies, and I'll go over brewy at another time. So I brought some videos because I think it'd be interesting for you to kind of see um, what these what sick kids look like. And literally, I got these from YouTube. This it's nothing fancy. These are YouTube shorts. This is a great YouTube video by Medspiration. Um, and I think it has a doctor talking over it. But I wanted to show you this. See the retractions, accessory muscle use. A little bit older kid. Look at that nasal flaring and that grunting. Look at that head bobbing. That's really rapid head bobbing. That's bad. Another form of it. Strider. And of course, it pauses out. So there's going to be some sounds that you're going to hear. I mean, one of the best things you do, go on YouTube, look this stuff up. It's always going to sound a little different, and it's different whenever we are trying to um, get it right on the test. Like you can learn the test, what the test is looking for and stuff. It's quite another thing to be out in the field and actually dealing with kids who are really sick. Like let's take a look at this kiddo right here. So we got this kid. What do you think's going on with him? You see that chest wall? Look how loose that is. They got that belly breathing. This is a kid in respiratory distress. Really bad respiratory distress. Now, let's talk about distress versus failure. Distress is they're working hard. They're they're tachycardic, they're tachypnic, they're working extremely hard to breathe. That's distress. Failure is they're not working anymore. They're starting to slow down. That's whenever they're getting agonal. Everything's starting to slow, not because things are improving, but things are getting remarkably worse. So in those situations, we definitely need to um, help with their airway by positioning them. So I can't really tell by the positioning, but the positioning on here ought to be where we have the baby has some towel rolls behind the shoulder because we want to put them in the sniffing position. Look in your EMT, advanced EMT, or paramedic textbook and put babies in sniffing positions. That is the optimal positioning for them so that they can get air directly into their airway, into their trachea, so they're not working as hard. Because if they're just laying flat in their stretcher on a bed or something like that, mom and dad might be doing the best that they know how to do, but they don't know what the sniffing position is unless they're in healthcare, obviously. Um, Oxygen. Don't be afraid to give them some oxygen, either blow by oxygen or via BVM if you need to support ventilations. We like using the NEOT up to 10 kilograms where I work, and a lot of places have started converting over to the NEOT. If not, there are infant and child size BVMs depending on what your needs are. Like for this baby, obviously we would be using like the infant size. We'd be putting a non rebreather on if that was appropriate for them. Let's look at this. There's another one too. This is a little video, um, and it's really interesting because like with this kiddo here, 3 month old, 25 days male. Can you imagine going out to that, like dispatched respiratory distress or shortness of breath, and you look and it's a 3 month old. You're like, oh crap, what do we do for a 3 month old? Same thing. Position their airway, get your NEOT, get your ventilator, get ready to help with ventilating these kids, getting help with managing their airway. A lot of times, managing their airway and breathing will help with their circulation and will get them to high points of success, so that we get them to the hospital just fine. So, um, I like Dr. Larry Melick has this on his YouTube video, but I love this. He's talking about how the airway physiology for if it's a little different. They do have a more compliant chest wall, which kind of sucks because they can end up with underlying injuries and we just don't know about it. So they have a greater reliance on their diaphragm because over their intercostal muscles because they don't have a whole lot of intercostal muscles. They don't have a whole lot of musculature at all. In fact, the sternocleidomastoid mastoid is a major muscle group that we like to use to help with our when we're in respiratory distress as adults, but children and kids just don't have it. They also have smaller and fewer alveoli than adults do, so there's less to recruit, and their airways are collapsible. Man, it's a nightmare. And that's not even to talk about the actual airway. Their tongue is proportionally larger. So if you've ever been to one of those hoarder homes where there's just stuff everywhere. You can barely get to your patient or get a little path in. That's what their airways are like because their tongue is so big. Now throw in a foreign body airway obstruction and swelling, and now you see that we're dealing with a potentially life threatening emergency with these kids. Things can go south real quick. So, with this video, I wanted you to see, hopefully, it loads. Oh, internet's so much fun. Looks like my internet may not load. Looks like there's a high minute volume alert that this would get with this kiddo here. That's all right. It's not loading, so I'll go back to my mind map. So those are the three components: air, appearance, work of breathing. Try it one more time. Nope. Of course not. That's all right. So yes, if there's increased work of breathing, but the appearance appears normal, they're in respiratory distress. If they have decreased appearance, and they put increased work of breathing, and I would say in failure, they're going to have anywhere between increase or decrease work of breathing. Generally, it's decreased work of breathing. So that's not exactly true. When they're in respiratory failure, they're failing to meet the demands. That VQ mismatch is extremely wide. They're not ventilating enough in order to match their perfusion. Because think about it. Remember VQ mismatch? So VQ, the V stands for ventilation. That's minute volume. That's tidal volume times respiratory rate. It has to match perfusion. Perfusion is cardiac output, and cardiac output is a function of heart rate times stroke volume. So, heart rate is how fast your heart's going in a minute. Stroke volume is how much volume your left ventricle will eject for every single pump. Well, if you're going really fast, you're putting out a lot of volume. Well, you have to have the oxygen to meet that blood that's circulating. If you don't have that, because now you're no longer tachypnic. Now your work or breathing is starting to collapse, and you're no longer breathing really fast. You're going to get hypoperfused, hypoxic very quickly, and so they can start showing signs of shock and decreased appearance. And when we say decreased appearance, that's pretty much anything like their tone, consolability, interactivity, gaze, um, all that stuff. If that stuff starts to look south for you, again, airway and breathing is going to be your best friend. And yeah, absolutely. At that point, we're starting to think of impending cardiovascular collapse. So this video's already gone on so long, it's already at 28 minutes, and I'll have to do a part two and maybe even a part three. But if you get nothing else out of this, I just want you to get that when it comes to kids, airway and breathing circulation, position the airway, get them into an optimal sniffing position, oxygenate them with a BVM or a NEOT, whatever device is most appropriate for them. And that's something else we can go over at some point too. And oxygenate them with high flow oxygen, always making sure you have suction ready. And again, have someone standing by with the patients' parents and stuff, letting them know what you're doing and why you're doing what you're doing. And that will help alleviate a whole lot of stress.